Hi, good morning, good afternoon, everyone. Welcome to today's webinar on programmatic adaptations for wasting in resource-constrained settings. Before we get started, we do have French interpretation available today, so if you'd like to listen in French, please click on the globe icon at the bottom of the screen. Next slide, please, Calvin. And next slide. Okay, let's get started. My name is Megan. I co-lead the Global Nutrition Cluster Program team. I'm joining from New York this morning. I'll take a few minutes to introduce why we're here today and what we hope to achieve over the coming hour. Firstly, a brief reminder of why this guidance was developed. As we're experiencing in real time, this year is not business as usual. We are facing unprecedented constraints with funding shortfalls, supply chain disruptions, and reduced partner presence. These have created real challenges in maintaining essential wasting services. This guidance was developed to help country teams make difficult decisions responsibly when full-scale programming simply isn't possible with the resources that we have at hand. Second, this work builds on pragmatic, collaborative process within the GNC. It was led by Action Against Hunger, Save the Children, and Concern Worldwide through the Wasting Global Thematic Working Group, and shaped by input from colleagues across the GNC at regional and country levels. The result is a grounded, scenario-based set of recommendations designed to be both practical, to be ethical, and most importantly, to be operationally feasible. Third, it's important to acknowledge that these adaptations may challenge our idea of what are previous gold standards. This isn't about lowering our ambitions or cutting corners. It's about navigating real-world constraints in ways that maintain, as best we can, equity, safety, and continuity of care. The guidance emphasizes principles like transparency, national leadership, and prioritizing the most vulnerable. Finally, today's webinar isn't just about presenting the guidance, it's also about us listening. We really want to hear from you, especially if you're in frontline roles, about what further support is needed from the GNC, both in terms of real-time support, but also in terms of different pieces of guidance. So your input will help us shape future updates and ensure that this particular piece of guidance remains a living, responsive tool to the needs as they develop throughout the year. Okay, our agenda today, as you can see on this slide, is fairly straightforward. We'll cover an overview of the guidance, followed by the South Sudan country experience, and then we'll move to a Q&A. And you will note we have a slightly longer webinar today to make sure that we have enough time for that Q&A. Just back to the translation, if you would like to pose a question in French, we will then answer that question in French, and colleagues who would like to listen in English, you will need to use the English channel on the interpretation. Okay, next slide, please, Calvin. Okay, so this is a quick snapshot of today's presenters. I won't go through these one by one, but everyone will introduce themselves before they speak today. So thanks from me for joining us. I'll now hand over to Calvin to take us through the presentation in more detail. Over to you, Calvin.
Thanks a lot, Megan. Just to confirm, can everyone hear me very well?
Perfectly.
Okay. Hi, everyone. Good afternoon, good morning. Thanks, Megan, for giving the rationale for why the guidance was created. We will now go into a more detailed presentation of how it was developed and then the different modules. So in terms of origins, the guidance was developed to help for humanitarian implementers, technical advisors, and program managers, especially those that are working the front line, to be able to use it to make useful adaptations that will ensure the continuity of Western services in the field. As we will see in the later in the different modules, it has a flexible and modular structure that will hopefully help practitioners prioritize actions and adapt protocols and maintain quality during this period where we have constraints. While implementing the guidance, we have three guiding principles that we recommend that partners have in mind during implementation. The first is that all adaptations should be temporary. should be justified and should be context specific. What this means is that any changes to standard protocols or service delivery should only be made when absolutely necessary. It should be based on a firm understanding of the local context and of the constraints. This means that adaptations should have a defined duration, should be regularly reviewed, and should have a clear criteria for returning to standard protocols as soon as possible. This means that once the constraint inherent to the context is no longer there, return to standard protocol should be done. The second principle is that adaptation should be agreed through an inclusive coordination and dialogue with partners and national authorities. This will ensure that any programmatic adaptations respect national protocols and leadership, reinforces local systems and safeguards the rights and health of the populations that are affected. And the third principles, which I already mentioned, is that there should be a clear criteria to return to standard protocols once the constraints no longer exist. Just a little bit on how the guidance was developed. It was developed through a collaborative initiative under the Global Nutrition Cluster's Wasting Thematic Working Group. The process brought together key partners, including NGOs, UN agencies, and some key donors. So as we can see on the second box, we initially started with 4 thematic subgroups. These subgroups were developed based on the constraints that were identified during a group discussion. Each subgroup then developed a technical note that identified key field level challenges and then proposed feasible programmatic adaptations. Now, these adaptations were informed by already existing global and national guidance, which includes the current 2023 WHO Wasting Guidelines and also the GNC guidance on management of wasting during shortage or absence of specialized nutrition products. So we weren't starting from scratch and be leveraged on what was already existing. And also this included operational learnings from the field. So once we had this information, then we developed a module based on this output. The current version of the guidance has prioritized 2 of these modules, as we will see. I'm looking at challenges related to supply shortages and service delivery constraints. The draft versions of the guidance was reviewed by different participants from including regional consultation to ensure that we took into consideration the feedback from a diverse group of technical advisors that will improve on the quality of the document. So the current document is focused on 2 distinct but interlinked modules. Module 1 which would look at providing guidance on maintaining services for children with wasting and undernourished pregnant and breastfeed women and girls in situations where there are shortages of nutrition products. Module 2 will look at addressing operational challenges related to service delivery and where we have to prioritize in terms of different geographic locations or where we have to implement with less staff. Across each module, we will have decision-making principles, prioritization frameworks, protocol adaptation recommendations in tabular forms that will help field managers implement adaptations. So we will now go to we will now move on to looking at the different modules. We will start with module 1 to have a deeper dive into what exactly is contained in that module. I'm going to pass to Kate to give us a deep dive on what is included in module 1. Over to you, Kate.
Thanks, Calvin. So I am going to, in 15 minutes, try to give you an overview of Module 1. And before I start, I just want to say a big thanks to all the people who were in the subgroup that brought Module 1 to its final state. So Module 1, as Calvin said, is about managing services for wasting in children and undernourishment in pregnant and breastfeeding women and girls during sudden nutrition supply shortages, which I know many participants are experiencing at the moment. On the right-hand side of the screen, you can see an outline for this module 1, and hopefully if you have the document open, you can be flipping through it. So the first section is the current situation, which we know is quite widespread supply shortages and stockouts. The purpose, as Calvin said, is to provide practical recommendations and actions to deal with these stockouts. Section 3 outlines 4 steps to adapt SAM and MAM services during nutrition supply gaps. Section 4 provides an outline of adaptations for the management of children with SAM, children with MAM, and then women and girls with low MUAC, also described as undernourished, I have learned. And then there are 5 annexes. So the first is RUTF stockout decision tree to try to help implementers move through those difficult decisions. Annex 2 provides a series of product substitution tables. Annex 3 provides alternative recipes for F75 and F100, which we hoped would not be necessary, but we are finding in several countries they now are. Annex 4 is a reducing dosage table for SAM, and it's based on weight, but simplified slightly from the recommendations in the WHO guidelines. And Annex 5 provides another table on reducing dosage for SAM, but when countries are already using the fixed dosage or simplified dosage protocol, which is 2 sachets for SAM and 1 sachet for MAM. Next slide, please. So the 4 steps, to give you an overview, to adapt wasting management during nutrition supply gaps. The first step is optimizing management of supplies already in the pipeline. So we know that supply management is often difficult, especially and has been, especially the last mile delivery. But now more than ever, we need to really come together and figure out where stocks are, how they can best be moved, used, etc. We need to have real-time information that we can, and strong coordination, so we can be sure that anything in the pipeline is optimized to the maximum. This document, however, is not a logistics management guide, so I'm actually not going to focus in detail on step 1, but if you read the document, you'll see some key principles for good supply management, and in particular, if any real-time stock monitoring systems have been used in a country, maybe piloted, we've heard of many small pilots, now's the time to scale them up. So focusing more on step 2, 3, and 4. Step 2 is about agreeing which areas and individuals should be prioritized. So we'll talk about geographic prioritization, prioritizing population groups, and then really emphasizing communicating and coordinating among stakeholders on those prioritization decisions, so people aren't confused, program participants don't feel left out, that it's really clear we're in a difficult situation and these decisions have been made. Step 3 is about identifying protocol adaptations that are appropriate and feasible. And there are some critical points to consider before initiating adaptation, and Calvin has already covered several of them. One is also to confirm the availability of the substitution product before making changes, because we want to avoid flip-flopping between, oh, we have this product this week, this product next week. So before you really commit to an adaptation to admission or discharge protocols, make sure that you really have that product in a sufficient supply. And then, as Calvin said, you need to set a minimum time frame for adaptations and define clear criteria for reverting back to the standard protocols. While implementing these adaptations, we have to ensure continuity of care, even if a product is not available. And we need to document all adaptations, feedback, and outcomes. And you can see there in the boxes, those are the annexes and other tools that are present in the guide relevant for that step. The 4th step is to consider product substitutions, and really over the short term. You need to prioritize products that are nutritionally and programmatically the closest to the original product, and the product substitution tables provide first preference, second preference, and third preference. Prioritize SAM treatment over MAM support, especially when RUTF stocks are critically low, and they should be applied only in exceptional circumstances. Next slide, please, Calvin. Yeah, so I'm just going to talk about these 3 steps. So jumping to step 2, part A, which is prioritizing geographic areas. These all are being discussed, we know, and should be confirmed at country level. But generally, we understand that there is agreement around prioritizing areas from IPC acute malnutrition and/or IPC food insecurity phase 4 or 5. And if in your country these additional criteria are not already included within the IPC, consider where there's the highest burden of acute malnutrition and where the highest number of children with SAM or MAM have been over the past 1 to 2 years. And finally, where imminent stockout of SAM and MAM commodities is expected. There are additional considerations you can see there on the right about where there is a high prevalence of undernourished pregnant and breastfeeding women and girls. Seasonal vulnerability, so consider when the timing and severity of the lean season, for example. And then where there are areas with no data, be sure you don't automatically deprioritize them. Use programmatic data or informed judgment because these areas may be the most in need. And then consider transportation feasibility, the cost efficiency and product shelf life. If you start moving products around, all of that has to come into your decision making. Next slide, please. And step 2 is about prioritizing individuals. So among children under 5, the first priority is SAM children with or without complications. We did not recommend prioritizing supplies for inpatients over outpatients, considering the public impact of both. The second priority is for MAM children with individual risk factors. And if you see the orange box in the middle, those individual child risk factors have been outlined in the WHO wasting guidelines, and a number of countries are currently identifying the best contextually appropriate set of risk factors to decide which MAM children may need to be prioritized for limited supplies. And then the third priority is for children, MAM children who do not have some of those individual child risk factors or some of the social risk factors you see there in the middle. And then for pregnant and breastfeeding women, the main prioritization criteria is for those with MUAC less than 210. And you may also want to consider where the woman is in terms of her pregnancy. Next slide, please. So moving on to step 3, the actual adaptations and adaptations to protocols to cope with stock shortages. You can see the overview there. So on the left, you can see 2 situations or 2 scenarios. The first is when you have a shortage or a stock out of RUTF, RUSF, or fortified blended foods for SAM and MAM children. And the second is when you have a stock out of fortified blended foods for pregnant and breastfeeding women and girls. So the main adaptation to SAM programming outlined here is to use a reducing dosage protocol in the later phase of SAM. And as I said, that is outlined in the WHO guidelines, but we do have one new annex which simplifies that dosage table. And the 2 main adaptations for programming for MAM is and both are kind of both different sides of the same adaptation. The first is to really prioritize RUSF and fortified blended foods for children with MAM with additional risk factors, which I just outlined in the last slide. And then managing MAM for children among children who don't have those additional risk factors, or if you just don't have a product for any of the MAM children, to use local foods or other products. And for women, as explained, we would prioritize those with MUAC less than 210 millimeters. And then finally, on the right-hand side of the screen is one of the most important principles, which is to continue to provide the fullest non-food support package possible. So even if you don't have a product, continue to provide a medical assessment and treatment, referral onwards, promotion of IYCF and care practices, referral to other health, WASH, food security and cash support, and home-based follow-up. Next slide, please. So now we're going to move on to a quick Zoom poll so we can hear from you. The questions are there. Multiple answers are possible for these two questions. If you're a country-based staff, please just answer based on what is happening in your country. If you're regional or global, please respond based on what you've seen in the countries you support. I think we can launch it now, Miriam. The first question is, which adaptations have you started implementing in your context? So maybe you haven't done any adaptations so far. Reducing RUTF dosage during the later phase of SAM treatment, simplified RUTF dosage or fixed dosage, meaning 2 sachets for SAM and 1 sachet for MAM, product substitution because of stockout, and MUAC only admissions, or any other. Question 2, oh, well, wait a minute. But when you're ready, question 2 will be about what product substitution specifically have you implemented in your context? Okay, so we see quite a bit there. Thank you, Miriam. So we see about a third of participants have done no adaptation so far. Simplified dosage seems to be the most popular adaptation. So 2 sachets for SAM and 1 sachet for MAM. Many countries adopted that long before this current pressure on stocks. Great. And reducing dosage has been implemented in about 23%. Okay, I think we can launch number 2. What product substitutions have you implemented in your context? At any point, but particularly during the current situation. Maybe you can move to the next slide, Calvin, while people are finishing up the poll. Okay, so I think you can all see the poll results. About half have said they've done no product substitution. Some have replaced RUTF with RUSF, or replaced RUTF or RUSF with fortified blended foods. Yeah, so quite a bit of substitution already going on. Okay, so I have 2 minutes left. This is an example from step 3 of our adaptation table. So I've shared the overview there. Each adaptation then has a table where we outline the approach, what it is, preconditions and preparations, and risks and actions to address them. This example is for managing SAM during RUTF shortages. Go to the next slide, please. Thank you. And then on to step 4, product substitution options. So if you hopefully have the guide open, you can see there are a number of products, RUTF, RUSF, fortified blended foods. But just to remind you again, always remember that you should continue to provide the fullest non-food support package possible. Medical assessment, referral, promotion of IYCF and care practices, and home-based follow-up. So this is just an example of possible substitutions for RUTF when you have no stock. And as I said, first preference is there, ready to use RUSF, an example, and then what the replacement amount would be. And you can see the second, third, and fourth preference for RUTF substitution are really only in extreme circumstances. Okay, next slide, please. And this is an example of the most extreme circumstance. And it was difficult to come up with this agreement because no one wants to give a SAM child, especially, but even a MAM child, this in place of RUTF or RUSF, but this is what we've recommended. So if you have absolutely nothing, a general food ration per sphere standards delivered by a context appropriate modality, that might be in kind, it could be cash, it could be voucher. and or promotion of local food recipes based on analysis. So use your nut val to optimize the nutritional profile, and then any additional products that could be used. So that's a LNS medium quantity or small quantity or micronutrient powders. And again, don't forget the non-ration part of the treatment. Okay, next slide. I'm just going to fly through these. These are just to show you, give you a glimpse. We do have those reducing dosages, dosage tables I mentioned, based on weight and then based on the fixed protocol. Next slide, please. This is the RUTF stockout decision tree. I won't go through it, but hopefully takes you through a logical series of steps based on some of the principles and adaptations already covered. Next slide, please. And the key takeaways for me are strengthen the supply chain management like we never have before. Adaptations are interim, as Calvin said, and in extreme cases, these are for exceptional and now very extreme cases or circumstances, but return to the protocol, but avoid flip-flopping. You know, just because you have a supply this day, next day, avoid that flip-flopping if you can. Adaptations must be agreed by all stakeholders. It's really for the cluster to decide, as well as the geographic prioritization. Give the fullest package and document what you do, when you do it, and monitor and address risks as best you can. Over to you, Caroline. Thank you.
Thank you, Kate. So my name is Caroline Antoine, and I am the Acting Director of Expertise and Research at Action Against Hunger France. So as you just presented, Kate, on Module 1 focus on supply-related adaptation, and with Module 2, we zoom out to look at the broader picture of service delivery. So how we can continue to deliver essential nutrition services in a context of multiple constraints, and particularly financial ones. So that may force us to scale down geographic coverage or reduce the overall volume of our support to health services. So this module provide a set of context-specific adaptation to sustain essential nutrition and health services, respond to operational reality like reduced staffing, fewer implementing partner, or restricted access, and particularly support continuity of care under severe constraints. So maybe what it is important, so beyond being a technical tool, it's also meant to support structured reflection at country level, because these choices should be driven by national actors, and the response need to be tailored to each context. So in the next slide, please, Calvin, thank you. We will go a bit into the key consideration that should guide this adaptation. So this module was developed based on core ethical and operational principles, with particular attention to equity, feasibility, and quality of care. So it builds on the global health cluster guidance on service prioritization, because we felt that it's important to promoting a more systemic approach to nutrition and health services, and to avoid siloed response and support more coherent decision-making process across the system. So the proposed adaptation should be led, as I said at the beginning, by the national actors, coordinating through existing mechanism, and designed to strengthen and not bypass the national system. So the objective is to preserve as much as possible safe, equitable, and quality access to services, and especially for the most vulnerable. And it is also important to maintain community trust through transparent communication, and to document the decision made to ensure transparency and enable learning at global level and also at national level. So the next slide, please. This slide outlines the 3 key steps on the decision-making process proposed in this module, in the module 2, to guide the context-specific adaptation. So the first step is to map the existing constraint, but also the current service coverage. So the aim here is to assess the available operational capacity, existing resources, and specific constraints that may require adjustment to the support currently provided to health and nutrition services. So the second step, it's about prioritization, given the constraint, which activity, geographic area, and target population are absolutely critical to preserve. And finally, the third step focuses on planning concrete adaptation based on the outcome of the prioritization. So the module identifies 4 main areas where adaptation may be considered. So the geographic coverage, target population, type of services to maintain or adjust, and the potential transition responsibilities to health authority or local actors. So next step, please. So the first step aim to assess the operational constraint faced and the current implementation capacity. So a key element here is to identify the nature and magnitude of funding cuts, as they do not all carry the same programmatic implications. So this analysis can also be an opportunity to explore possible internal reorganization to maintain some level of service coverage despite constraint. And finally, it is essential to anticipate a key deadline, whether related to internal budget cycle or donor timeline, and in order to enable a managed transition rather than a sudden stop. That it's more easier to say, of course. So the next slide, please. So the step 2 is about defining priorities when the coverage previously applied, whether geographic or in terms of services, is no longer feasible. So the objective is to maximize impact and equity in a constrained context through a transparent and criteria-based decision-making process. So this prioritization is structured around 3 dimensions. The geographic prioritization, so the criteria used are the same as those presented in module 1 by Kate earlier. And but in module 2, these criteria have been complemented by more service-specific consideration, such as the Ministry of Health capacity to sustain services, the presence or absence of other active partner, and the strength of referral system, for example. Another dimension is the target population prioritization. So here again, it's the same that we discussed just before, and the aim is to ensure that the most vulnerable group are protected, even when coverage is revised. So these criteria are aligned with the logic presented before, and by type of activity. So the idea is to distinguish between essential intervention to maintain, so that can be reorganized or integrated, and so that could be temporarily deprioritized while respecting ethical and white line and minimum service standards. Next slide, please. So let's now move to the step 3, so which is about defining the actual adaptations that can be implemented. So based on the analysis on prioritization outcome we discussed in the previous step, so the aim here is to reorganize, reduce our transition services, so depending on operational capacity. We know these decisions are never easy and will depend on the combination of factors, internal resources, coordination with national actors, and what community are already experiencing on the ground. So next slide, please. So before we move on to the concrete example presented in the table in the module in the step 3, we would like to hear from you first. So here is a pull question. So it's a little bit similar to the first question. So what adaptation have you implemented in response to budget cuts that affected service delivery capacity? So you can select answers. So here are the options. So prioritize geographic area or facilities, reduce frequency of follow-up visit, integrated services into primary health care, delegated tasks to community health worker, suspending non-essential activities, or transition some services to the some activity to the Ministry of Health. And the last is other or no adaptation. Okay, so thank you for your responses. We can already see that several types of adaptation are being implemented across different contexts, from task delegation and prioritize geographic areas or facilities to reduce visits. So this really highlights the diversity of responses and the need for context-specific strategies. So let's now take a look at some example from the guidance document. Next slide, please. So not to go through them in detail, but to show how the tool is structured and the kind of question and option it provides to support your decision-making process. So, so we are coming back into the step 3 with this table, so which focuses on planning concrete adaptation. So the slide presents the two first area of the adaptation planning table introduced in this step. So in the first line on geographic coverage, and the second one is the target population. So among the example of adaptation listed here, you will see the prioritization of certain area based on context-specific criteria, such as, so it's the same criteria that we saw before with Kate. And in fact, there is some example in the prioritized area mitigation measure can be considered, such as periodic mobile outreach or the strengthening of community-based referral mechanism. So when it comes to target groups, some cases may be prioritized in constrained setting, whether or not they present with complication, with medical complication, but maybe what is essential is to maintain a holistic approach to the child. So that means that even a child without severe anthropometric deficit or the moderate ones should be able to access health services, and if they are sick or at risk and benefit from integrated care within the system. And finally, it is crucial to continue strengthening preventive activities, including brain preserving IYCF in emergency, community-based referral mechanism, and what it's also another topic, but these are foundational element, and especially in a resource constrained setting. So the next slide, please. Next slide. Thank you. So we remain here within the step 3 on the module, and this final section of the table focuses on the typology of services. So in a context of constraint, it is essential to preserve life-saving and essential services, particularly those related to the treatment of severe acute malnutrition, management of common channel illnesses, and IYCF services. So it may be also possible, some activity can be reorganized, integrated into the primary healthcare services. And so you can see in the document on the left several type of adaptation. And finally, this table also invite us to reflect on the transition of certain intervention to national health system. So in many cases, existing programs are already designed to support national health system. They do not operate in a parallel, but instead aim to strengthen what already exists. So in a constrained context, the objective is therefore to adjust this support, sometimes shifting to a lighter or less direct form of assistance while continuing effort to align with national models. So next slide, please. It's the last one on documenting. It's after we will go to the next presentation, the next part of the presentation. So we are the final step of the module, which focuses on documenting the adaptation that have been implementing. So and this is a strategic priority in a context where programs are evolving to adapt to constraints. What is essential to document what has changed, why it was done, what effect it has had, and both at the patient level and at a broader scale. In this slide, I outline the 5 key actions we have identified. And what we would like to propose now is to go further on this topic by setting a sub-working group within the GNC to develop practical documentation tools and, where possible, to identify pilot countries or contexts to test these approaches in a more systematic way. Thank you.
So just before we move on to the South Sudan presentation, we just have a quick poll. Calvin, I think you can move forward in the presentation. We can get ready for that. Just looking for your input here on how soon do you feel we will need to revise this document? The options are 3 months, 6 months, and 12 months. I appreciate your input on this, and we'll hand over to Helen to give us the presentation from South Sudan. Thank you.
Thank you all, and good morning and good afternoon to all. Just confirm you can hear me.
Yes, go ahead.
All right, thank you. My name is Helen Martin. I'm a nutrition specialist with UNICEF South Sudan, and I will be taking you through South Sudan's experience in adaptations related to resource-constrained context. In South Sudan, our focus is on life-saving interventions. And just for the purpose of this presentation, in South Sudan, we have 10 states and greatly divided into 3 regions. So you will hear me referring to the regions a lot in the and during my presentation. And this map is our IPC projection map for April to June this year, but now we have an updated one, updated again April to July 2025 with a completely different projection. So we have counties that have shifted and moved their faces. Before I move on with the presentation, I just want to acknowledge it wasn't an easy journey to do these adaptations, but I just want to acknowledge all the partners in South Sudan, the nutrition partners. It was a collaborative work, and with the leadership of our team lead, the Chief of Nutrition, Ruth, who was able to lead us in navigating through this process. Next slide, please. Right, just to give you an overview of the program in South Sudan. In South Sudan, we focus on key three areas, and these are the three outputs we have. So we have governance and policy, where we focus on strengthening government capacities to deliver quality and multi-system nutrition. To deliver nutrition in using the multi-system or sectoral approach. And then we have prevention of all forms of malnutrition. And lastly, we have the treatment of malnutrition. So for the how do we deliver these outputs? We use high impact interventions, and this looks at the prevention against wasting, micronutrients, malnutrition, and amongst children and women. And we also look at the large scale treatment of severe wasting and also adolescents and maternal nutrition. So some of the approaches we use really focus on creating and enabling an environment to scale up high impact interventions. We also use the multi-system approach for prevention of child nutrition, integrating with the other sectors. And we also engage in the food system through quality diet provision for children. It's a new thing we're doing in South Sudan. And through the health system by integrating nutrition in the health system delivery. And this is what we actually maximize during our adaptation when the funding gap occurred. And then engaging communities. So in partnership, we worked with the government at both national and state level, and the ministries that are lined up there, local community, the civil society, our implementing partners, but also the sister agencies. We also work together with the academia and the private sector. Next slide, please. Okay, so this is now the key slide for the program adaptation that took place initially from January 2025. Our plan was to reach 500,000 children, half a million children with some treatment. That's 80% coverage across the country and covering the whole country, the 10 states that I mentioned. And we also have a plan to pilot the new WHO guidelines. South Sudan is amongst one of the first 5 runner countries to implement or pilot the new WHO guideline, and this was planned to take place in 2 states, that's Lakes and Northern Bergazal, and it's in one of the regions I talked about, and also prevent malnutrition across all the states by doing what is listed there. So the first shift in Feb, when we had the funding freeze, but with exemptions only for life-saving grants. So what we did together with our partners, as I mentioned earlier, we looked at where can we meaningfully utilize or redirect or use this limited funding. So we looked at the high burden states we have in South Sudan, and that's the Greater Upper Nile states, which comprise of 3 states. But we also said, let's look at the 33 counties, which are IPC 4. So that was the first change or the first shift in our program to focus 80%, maintain the 80% coverage we talked about in January in the 3 high burden states and the 3 counties which are IPC4. And then for the remaining states, we do 50% coverage of the nutrition activities, and we won't be able to do surveys in those in the state, in the country, but we maintain prevention across the country. Before we can even move on with this shift, we had a complete freeze of all grants. And just to mention, South Sudan depends 100% on external funding, and US aid or BHA is one of our biggest funding. So it was a big shock for the nutrition program in South Sudan when all the grants were frozen. So now that we also had to sit, a committee was formed comprising of UNICEF, UN sister agencies, and the partners to see how do we move on from here. So now this led us to the second shift in March, where we now focus on what approach will we use to deliver service. Next slide, please. Right. So for us to be able to now reprioritize what we have already prioritized, so we had to look at what criteria we have to use to do that. So South Sudan then decided to use 3 criteria, that is looking at the impact, what solutions will this reprioritization provide to children who are at 12 times of dying. These are some children, and what impact will it have on children who, if they do not get vitamin A, might die, because vitamin A reduces mortality by 23 to 34%. Breastfeeding. So we're looking at the impact of the the change we're going to make on this, but also the scalability. So how much of this will cover the country? So we know that vitamin A covers the country, deworming, mass MOAC screening, and MIOIC and counseling. These ones cover the country. But looking at the budget, that means what we have will only have limited coverage in limited states if we want to do some treatment, and also for prevention it will be limited. And the iron folic acid supplements is something that is also coming up in South Sudan, and this will only focus in 8 countries. So we use this criteria to now reprioritize the second shift. Right. So next slide, please. Right. So we also looked at key principles of how to now deliver or to go about what we said we will do. So some of the principles we looked at to guide us was to focus really on life-saving interventions. And at this, we had to now like revise the activities on our program documents, and we also reduced our partners from 29 partners to 22 partners, but we tailored activities that will go into the program document that will focus only on life-saving interventions. So we said we will fulfill as much as we minimize activities to now strictly focus on life-saving activities or interventions. We will have to fulfill the UNICEF's core commitment to children. And on the right, you can see the commitments there that we focused on for 5, 6, 7, and 8. So we also said we will be, one of the principles will be to align with the sphere standards in humanitarian context. We will also maximize available resources. And one of these is the health system, health sector transformation project that is a government-led but UNICEF supported, which we maximize for the service delivery for nutrition. And we also said we will maintain footprints in areas of high levels of malnutrition. That's the 3 greater Upper Nile states and counties with IPC4. Right. So, and then we also assume that partners will have core contributions to make this happen. Of course, we know partnership in UNICEF is UNICEF contributing, and partners also contribute. Next slide, please. So now these are the changes and approaches that are currently being implemented in South Sudan. So the first approach was to focus on the counties with high nutrition, high burden of malnutrition and IPC4. So we have the three states in Greater Upper Nile states, and we have a few counties that some counties that are IPC4 that are focused on. That's the approach one. And in this, we maintain all partners who are now approach two, we focused on counties with high burdens, and these are in a few counties. Here now we use, like I mentioned, the HSTP, which is the Health Sector Transformation Plan, is a government led by UNICEF supported. So we have program documents with partners. So some of these partners overlap with nutrition partners. So some of these partners who are having both HSTP and nutrition PDs were merged. So we had to terminate the nutrition PDs and have nutrition activities added onto the HSTP or the health PDs to cover the nutrition service delivery in those counties, and others who are having PDs for the Greater Upper Nile region. In approach one, we maintain their PDs to cover these other locations. Now, approach three is we transitioned to the government in three states, where we said now the government will take lead in providing a comprehensive nutrition service in those three states. And then what we did was we assigned one partner to oversee and guide the government in implementing or now providing service and taking lead. And now there is a full process related to that, where we have to assess the capacity, do some capacity building, clearly define the role of the partner and the role of the government and things like that to facilitate the transition. And it's important to mention that in South Sudan, we have 91 stabilization centers, and all these are maintained. These are crucial, critical service points were maintained in all the states. Now, so some of the principles that we use to help implement the approaches is we really used government staff in nutrition service delivery. Previously, our partners recruit nutrition cadres based on their contracts, but we say now that we do not have the money, we will have to use the existing resources. So on the HSTP, we have 1,400 nutrition workers, which we are currently using them. Yeah. So, and with this, we also mentioned that we now will be using the government approved incentives. We will not be using each partner having their own incentives. So the incentives have been harmonized and to be based on what is approved by the government of South Sudan. And we also really worked with the government and leveraged the government's leadership in communicating to the state ministries, to the level of the county health departments, to support the adjustments that we are working on, and to emphasize that we should use the government salaries and incentives for the nutrition frontline workers. And we've also have the Ministry of Health to do a circular to the NGO forum and partners to be able to harmonize the incentives and use the recommended or approved incentives. Now, with having the government on board, definitely accountability rests with the Ministry of Health in ensuring that whoever is on the HSTP is now the accountability and responsibility of the government to ensure that services are being delivered. Now, for the transition states, we use the simplified approach because it is a reduced capacity, and we build the bicycle as we ride. So there we're using simplified approach where for admissions, we have simplified admissions or enrollment to only family work for screening, and we also use MUAC for admission, and we have the reduce frequency of visit where possible because it can be challenging in other locations. And we also modified the dosage of RUTF for for these three uh, for these three for these three states. And yeah, so also simplified discharge or exits of children from the program. Yeah, so I think most likely this is my last slide. Let me see. Yes, yeah, thank you, and over to you.
Thank you very much, Helen. Thank you very much, Kate, and thank you, Caroline, for the fantastic presentation. So today, the objective of today's webinar was to provide a deep dive into the content of the guidance to support its uptake and practical implementation at field level. But just beyond a deep dive into the guidance, we want to hear from you. And this is the space for you now to raise concerns about anything that feels unclear, any of the adaptations that have been presented so far that maybe seems difficult to apply or that you might find yourself in a dilemma. We welcome all of your questions and reflections and suggestions. As we saw in the pool, quite a number of partners are already implementing some form of adaptations. We saw that 57% are doing some form of geographic prioritization, as we can see in the case of South Sudan as well. They're implementing a number of adaptation. The version of this guidance we are producing it such that we can learn and constantly improve from the feedback that we are getting from you. So please feel free at this point in time. You can raise your hand to ask the question or raise any concern. That will help us a long way to improve the document as we go along. Feel free, as Megan mentioned initially, to ask in French if you speak French, or you can ask in English. If you speak English, raise your hand or just drop the question in the Q&A chat, and then we would either give you an opportunity to speak or read out the question so that we can provide feedback. I will just take this down so I can see the hands in the chart, the hands that are raised. Does anyone have any question or concern? I mean, this could be related to any operational dilemmas that you currently have been facing in implementing the adaptations that you have been implementing at the field levels, or it can be related to what we have just presented, any particular aspect that seems unclear, or we may have missed out on some key adaptations that you might need at field level to help you with the constraints that you're currently facing. You can raise that concern here, and then we can see how in the different versions, that the subsequent versions, how we can include that that feedback.
Calvin, there's an hand of
Okay.
Christopher.
Oh, please go ahead. I can't see the hands for some reason. Please go ahead, Christopher.
You are sharing, so let me unmute the.
Okay.
Please go ahead, Christopher.
Please go ahead, Christopher.
I didn't know if certificate is a problem. So he didn't have any other thing. So what should I do? I sign in? Yeah, this is true.
Christopher, did you raise your hand? Did you have a question? Okay, we
I
seem to
think
have, yeah.
He's muted again.
Yeah.
Okay.
We would like to hear from partners. As anyone has had any challenges, maybe implementing geographic or population prioritization, or implementing any of the adaptations that we mentioned. It could just be you can share your experience, or go ahead, Christopher. You seem to be unmuted. Do you have a question?
Hello, this is me, Dr. Taban Isaac.
Okay, please go ahead.
Yeah, thanks a lot to all the presenters. Specifically, I have a concern related to the adaptation. Let me just say, related to the simplified approaches of using RUTF. You know, in South Sudan, we have what they call the CMAM guidelines. And I think there is that gap of how to link up the simplified approach with the CMAM guidelines. That has been really an issue which I myself experienced, in a sense that since we are actually transitioning from the partners getting their staffs to implement nutrition activities to the government incentivized staffs who might not be well versed with other, let me say, processes of how to give to RUTF. It was so much important that if the simplified approach was cascaded across, it will really help the government staffs who are not yet well versed with other nutrition services. And maybe that is what to pick up with Ellen, to say that practically when I visited some of my locations, the government staffs have not yet picked up on how to go about with the simplified approach, because there has not been any official communication, and still there's that confusion into whether to go with the simplified approach of 2 circuits of RTF and 1 circuit of RSF, or we still go and use the usual approaches. And again, looking at the modalities of how to go about with this, if it's not communicated clearly, then it will also cause some sort of confusion in terms of implementation on the ground. So the approaches are good. However, if it's not really cascaded at this level, then it will also cause some sort of confusion. But otherwise, it's really so good. Thank you.
Thank you very much. Helen, do you have any comment based on what he is on what he said on this concern?
Yeah, sure. And thank you so much, Dr. Taban, for your question. I think I just need to make one clarification. For the 3 states, transition is happening in 3 states, and I'll name the states because now Dr. Taban can pick them up. That's Northern Bergazal, not Northern Bergazal, Western Bergazal, Central Equatoria, and Western Equatoria. And these are locations strictly where we recommend the full transition, and the use of the simplified approach. For the rest of the country, including where TFAN works, we continue to use the CMAM guideline as it is. We are not changing. So I think that clarity should answer your concern, Dr. Taban, that for the rest of the country, we are not doing simplified approach. We understand that the government staff that are working with partners, they need a lot of capacity enhancement. So that is where our focus should be. And I think the modality has been clearly defined to be on job coaching or mentorship. We do the job while we are there with them so that it sings, because for classroom trainings, there is no funds at the moment for that, but on-job training has been recommended as the modality to have or to bring up these government staff to speed. Thank you.
Thanks, Ellen. I think that is crystal clear, and thanks so much for the clarification.
Yes, okay, thanks a lot. So we have some questions that are popping up in the Q&A chat box. There's one question of, have you considered highlighting the work of community health workers as recommendations, that is to increase coverage of nutritional treatment, especially in remote areas? Yes, I think in the second module, one of the possible adaptation, obviously, is to decentralize the management to community health workers. The risk here is the caveat here is that we have to ensure that they are adequately trained to screen and to manage uncomplicated cases of malnutrition. And then we have to obviously have a system where we have supervision to ensure that the quality of care they're providing is not jeopardized. Karen, I don't know if you have anything to add with respect to this, or that's okay. Right. If there's another, please go ahead.
Yes, no, thank you. I just answered in the checkbox management, and yes, but absolutely, the role of the community health worker is highlighted in the module 2 as one of the programmatic adaptation. So as you said, it's but that is done in alignment with the ministry, with national policies, and as you said, with the proper training, supervision, etc. But maybe what I can add, it's we also emphasize that this kind of adaptation should not be seen as a shortcut of a cost-saving measure, but rather as a part of a broader approach to strengthen community level service delivery and ensure continuity of care. Thank you.
Yes, just to build on that, one of in the guidance, we also mentioned some key ethical red lines that should be considered. And as in the example that was just given, the consent that was just read from South Sudan, it is relevant. It's really important to involve different partners, involve the Ministry of Public Health when we are deciding on what adaptations we want to implement. And then once this has been decided, then to disseminate this information. And more often, they might need to build the capacity of the staff that are going to be implementing these new adaptations. If we have a reduced protocol and they're used to just implementing the standard protocol, then there will be a need to train the relevant staff in providing this support so that we don't jeopardize quality. And also, again, to maintain and monitor the quality of services as we implement to ensure that we are not doing more harm than good, and to document some of the challenges that we are having, and then to make regular changes on adaptations as needed. Please feel free to raise any other concerns. We are having okay, there's a hand up. Hamed Adesola, please go ahead.
So we are at time.
Hamed.
I'll just allow Hamed to talk, and then we need to hand over to Megan.
Yes. Hamed, you're muted if you're talking. Please go ahead.
Yeah, can you hear me now, Kevin?
Yes, we can. Please go ahead.
All right, yeah, just to share a little bit of experience on the Nigerian adaptation strategy. So specifically on the geographical prioritization. So what we do in Nigeria, we looked at multi-sectorial severity index criteria. For example, area with IPC level 4 to 5, and also areas with food insecurity, Kadamon, I say phase 4 to 5. We also look at areas with of violence affected areas, and areas with high number of internally displaced populations for our geographical prioritization. For the target population, we did not prioritize, or we did not change the criteria for some management. So we looked at we maintained the same criteria for some targets for inpatient and outpatient programs. I have a quick question on the activation of the local foods. I think that's the fourth recommendation. I think there are a lot of factors we need to consider before we activate the use of local food recipes. For example, the capacity of the vendors or the farmers to deliver these food recipes, these local food recipes, and also the inflation factors, the economic factors as well. I think these are factors we also need to put into consideration before we activate the use of local food recipes. In Nigeria, regarding dosage of RTF or simplified protocol, what we use currently is we adopt 2 sachets of RTF per child, regardless of the weight of the child. So a kind of blanket 14 sachets per child. That's what we currently use in Nigeria. And what actually informed us to use that was we looked at the experience and the capacity of the human resource for health that we have in country. So it would be a bit difficult for the health workers to switch once the child reached the MAM criteria to switch to one sachet. So we decided to go with a kind of blanket 2 sachets per child. Thank you.
Right. Thanks a lot, Ahmed. Over to you, Miriam.
I'll take over.
Oh, Megan,
All right.
sorry.
Yeah, no worries. Okay, in the interest of time, I'll just take 2 minutes to wrap us up. Next slide, please. Okay, next slide as well. I just want to say a huge thank you to everyone that presented today. And also just the number of people that contributed their time and expertise in developing this guidance. I think it was truly a collaborative effort that spanned different levels and different parts of our GNC community. So all of this time is obviously just a contribution in kind to the public good of the GNC. So a huge thank you from the GNC program team for all of that effort and collaboration. Just one quick word in terms of how to request new support from the GNC. We know that with all of the changes, new questions are coming up. So next slide, please. Please do know that the GNC core team, our help desks, are on standby next slide, I think, to respond to any questions that you may have. So please do reach out. No question is too small or too big. I just want to say a huge thanks to our donors to the GNC. Putting on these webinars also takes resources. So we thank our donors and all of our partners who contribute their time. We do have a evaluation. If you wouldn't mind taking just 2 minutes to complete this evaluation, it really helps us to continue to improve each of the webinars that the GNC hosts. Okay, with that, I will say thank you and have a good afternoon, evening. Bye, everyone.
Bye.
Bye, everyone.
Bye, thank you.
Goodbye. Thank you.